Here we offer different types of immunotherapy technologies integrated in one strategic plan. We give immunogenic cell death immunotherapy, vaccines, so to actively stimulate the immune system, modulatory immunotherapy, and passive immunotherapy. Well, the best results are here analyzed with brain cancer, the glioblastoma, because we have a lot of patients that can be analyzed in a proper way. But in fact, this technology works for each cancer that has a tumor antigen in a patient that has a functioning immune system. So we call that an agnostic therapy. When the conditions are there, a tumor antigen and a functioning immune system, it should work. The easiest way is sending an email with a summary of the disease history and the treatments that are given till then. And over the email, I reply quite immediately, and then the contact is realized and we get more and more information and we give more and more appropriate information for the concrete question. Not necessary. We sometimes make a first Zoom short consultation to answer in a more easy way some questions of the patient and to have a first assessment from my side. But once it comes really to starting the work, the patient has to come to Keulen. Not necessary. Now we have with DeepL and Google translation and AI translation programs. So I think in the first place it's not needed. When I ask it because I feel the need, then it should be done. But in the first place, not. There are absolute specific conditions. So first of all, the self-performance of the patient, which is called the Karnofsky Performance Index, should be high enough. The patient should have still acceptable quality of life, should be functioning. That's one element. And a second element is the traveling to Keulen and staying in Keulen in an ambulant treatment setting should be safe and feasible. That are the major requirements for everybody. It depends on the flow of information, and it depends then also on the clinical situation of the patient. Has radiotherapy been given or chemotherapy? Then we adapt our first contact schedule to the ongoing treatment. Usually, however, there is no waiting list for the patients.
Mm-hmm. So availability is something like...
It's good. So we can handle till now all the questions within acceptable timelines. Yeah, we choose our immunotherapy technologies depending on the ongoing standard of care in the local oncology center. So we can easily combine radiotherapy and chemotherapy with some kinds of immunotherapy. Not with all kinds of immunotherapy, but some, yes, of course. We are very fortunate that we have here a Polish-speaking nurse who helps and like to help the Polish patients if a translation is required. I would say at least 3 times. But it all depends on when the immunotherapy comes in the global treatment strategy. If the patient, for instance, takes still chemotherapy, then we already come in with immunotherapy approaches, and that of course takes as long as the chemotherapy is running. And after the vaccines, if everything goes well, we also continue with maintenance immunotherapy at a lower frequency. So it's really depending case by case. It can be fast, it can be slow. It's really depending on the individual response to treatment. Sometimes we see already in tumor markers a beginning of a response to treatment. Sometimes we only see a stabilization of the disease, of the cancer volume, and only much later it starts to reduce. But if you already can stabilize the disease, that's already the first glimpse towards a response to treatment. First goal is always stabilization of the disease. But if we have a response to treatment, we also start to prolong overall survival in global. And that is of course the ultimate wish, that we have long-term overall surviving patients, which is a possibility. The biggest side effect is coming to Köln, because that's traveling, that's a stress for the patients, for the family. But otherwise, the side effects are very minimal, because we do not give external toxicity to the person, but we stimulate the immune system of the person from itself. Sometimes an immune reaction can give some symptoms. For instance, in the brains, you can have some brain swelling. You even can have some epilepsy. That can all occur, but that's then rather an effect than an adverse reaction or a side effect. So also there we have to see how you categorize the symptoms at that moment. We like, of course, to collaborate with the local oncology teams, but we can accept and understand that the local oncologist is sometimes very skeptical. I think at that moment communication is the best. And if there is no wish or need felt by the oncologist to communicate, then we respect that and we try to understand and guide everything without further communication. That is mainly because of regulations and scientific assessments of results. So regulations are very strict for that type of therapies, oncolytic viruses and dendritic cell vaccines, which are advanced therapy medicinal products. That's one. And second, the discussion on the evidence of these innovative therapies is still going on. This is a very complex team, and insurance companies sometimes are very restricted in what they accept as evidence of efficacy, and that is current discussion in a lot of countries. Well, first of all, so expensive, I would make that in a sort of relativation. I think it is in fact not at all expensive, but the question is who has to pay? And if the patient of course has to pay from own pocket, then it is for the patient very expensive. But if you see to other innovative drugs that are commercialized by pharma industry, much times it's even more expensive than what we in fact do with our very complex advanced therapy medicinal products. So that I would make a relativation. It's all the matter who has to pay for this treatment. The Polish patient, as far as I assess, because I'm not the financial expert here, I see that patients start doing crowdfunding to get the money together. There are sometimes foundations who help patients, especially for children, who help the patient for the treatment. Sometimes the local oncologist is really supportive to write notes to the insurance for getting the money available. So there are different ways of handling at the moment, as far as I can see in the Polish families. Yes, we try to help these patients, but of course we should really discuss with the patient and face the reality at that moment. And so we do not aim to treat up to the extreme end. Sometimes we have then to say, no, in fact, this is not anymore an available treatment for you. And then we also discuss that this is not the best strategy to move forward. I think a life expectancy of at least 3 months should be available, although that's very difficult to assess as such. Yes, we have cases that certainly have benefited from these treatments, and we have also published such cases in our scientific publications. There are also stories available in Facebook groups, on internet pages, but there are several cases that really have benefited from our therapy. We have, of course, to say, as we usually try to combine our immunotherapy strategies with standard of care and other treatments, you never know who has done ultimately the difference. I think the difference is sometimes really the combination as such. The standard of care is not completely working. The immunotherapy maybe on its own is also not completely working. But both together in a good combination, they make the difference. And then we have to be honest that we have contributed in the global treatment strategy that ultimately realized that the patient has a new perspective in life.